Welcome to the 8th Annual Seattle Area.
The Seattle Epidemiologic Research and Information Center, in collaboration with the Department of Veterans Affairs, the VA Employee Education System, and the University of Washington Departments of Epidemiology and Biostatistics, presents the 8th Annual Epidemiology, Biostatistics, and Clinical Research Methods Summer Session.
Good morning, everyone. Welcome to the 8th Annual Seattle ERIC Epidemiology, Biostatistics, and Clinical Research Methods Summer Session. My name is Ed Boyko. I am the course director this year. The title of the course is Epidemiologic Aspects of Military Post-Deployment Health Conditions, Natural Disasters, and Terrorism. And it's my pleasure to introduce to you Dr. Greg Gray, who's today's speaker. He's a professor of epidemiology and director of the Center for Emerging Infectious Diseases at the University of Iowa College of Public Health. He's a retired captain in the U.S. Navy and a graduate of the Naval Academy. He's conducted 32 epidemiologic studies among Gulf War veterans, and he served as director of the DoD Center for Deployment Health Research while in the military. And today he'll be talking about epidemiologic aspects of military post-deployment health conditions. Dr. Gray.
Thank you very much, Ed. It's a pleasure here to chat with you about something that I've worked very closely with a large part of my professional career, and that is the health of Gulf War veterans. We need to start off with the concept that war is very, very traumatic, and the stressors of war recorded in this nice little description online, they're shown here, but and of course they vary by the war theater, but it's a tremendous insult to man's physical and mental body when you're put in harm's way in a foreign land. And certainly we could see that these various stressors among our Gulf War veterans and our present veterans of the Afghanistan and Iraq theaters. War syndromes have been well documented in the medical literature. Here are two recent reviews, one by Jones and one by Himes, and the end of a book documenting these from World War I. So there's quite a bit of literature out there about the sequela of war exposures. Historically, the syndromes have been called different things by the various different observers. In the U.S. Civil War, some of the post-war complexes were known as Da Costa syndrome, irritable heart, and nostalgia. In World War I, we had effort syndrome, soldier's heart, shell shock, trench neuroses, and neurasthenia. In World War II, the terms become a little more familiar because they're in our vernacular. Combat stress reaction, battle fatigue, and combat exhaustion, and then with Vietnam, post-traumatic stress disorder. When we talk about Gulf War veterans, it's important to discuss a little bit of the facts to lay the groundwork here. We had some 697,000 U.S. military personnel deployed in August through July of 1990 and 91. In addition to those, there were 53,000 UK veterans or UK personnel and 25,000 French and 4,500 Canadian, and then smaller groups of I think it's 30-some nations. Their mean age was 28 years, about 7% women overall. We had a large component, much larger than we have in previous conflicts, of reserve and National Guard personnel from this country. Very few casualties associated with the war, and we had almost the same number of non-battle injuries, so a lot less mortality than we expected. The ramp up and the ramp down of deployments were very rapid, and we expended, it's been estimated from $61 to $71 billion. The timeline is shown here. On August 2nd, 1990, Iraq invaded Kuwait. Our first U.S. forces arrived in theater several days later, on August the 8th. The Security Council from the UN authorizes use of force in November, and then the Allied coalition begins the air war, 34 countries. The oil wells we all know about. It's one of the leading exposures that are of concern among the veterans. And then we have the ground war beginning on February 24th and ending on February the 28th, a very brief conflict. Of interest, in March 5th of the same year, 1991, there was a destruction of munitions at a place called Camisea that subsequently came into interest for a number of reasons we'll discuss. A ceasefire on March 11th, and then most of the people had gone home by July 31st, with the oil wells extinguished by November of the same year. Well, subsequent to that deployment, there were quite a few allegations among the veterans. And of course, everyone eventually in time, or many people eventually in time, will have some sort of morbidity. And the questions were, with these unusual exposures in the Gulf, were these symptoms and signs of medical illness associated with those unique exposures? And this is a list of them, and they vary greatly. Gulf War veterans are dying like flies, was one of the allegations. They were supposedly succumbing to cancers, sleep disturbances, respiratory problems, diarrhea, a very rare neurologic condition, amyotrophic lateral sclerosis. They had very hard to measure symptoms and signs such as sexual intercourse pain, spouses and children having similar rashes and such, loss of concentration, headache, etc. And then more objective findings were alleged, such as having children with birth defects. I like this little graphic as it displays where the allegations were. They ranged from things that were very severe and objective, such as deaths and cancers, to things that were very difficult to objectively measure, symptoms and chronic disease, and birth defects. Birth defects being a little easier. Well, initially, what our government did was investigate some of the claims. And these are two of the investigations led by the Department of Defense. There was another one led by the Veterans Affairs, I think, in the Southeast some months later. Walter Reed Army Institute of Research dispatched a Epicon team in 1992 to visit a reserve unit in Indiana that was said to have a tremendous amount of morbidity. Their report was consistent with stress-related post-war illnesses and didn't really satisfy the veterans, as they thought they had something unique from the Gulf War. In 1994, a similar investigation was conducted by the Navy Environmental Preventive Medicine Unit No. 2 among Seabees in Alabama, as Seabees were some of the folks said to be the most symptomatic. Neither of these studies identified a unique pattern of illnesses that could be called a syndrome or implicated specific exposures that might be associated with post-deployment morbidity. Nevertheless, the veterans of the Gulf War kept asking this question, why are we sick? And there was a tremendous interest in this topic, both in the news media and on the internet, that seemed to amplify this question. There was a recognition that there were quite a few exposures that were unique in the Gulf War. Not always unique. I mean, some of these exposures were associated with other deployments, and some were not, but nevertheless of concern because there was an understanding that these exposures could be the partial etiology or the etiology for serious medical outcomes. The problem, of course, is with these reports is that exposure data were very lacking with this deployment. Vaccine records were very sparse. Clinical records were sparse or missing and not centralized when they were available, often in paper, not electronic. Environmental exposure data were lacking. I mean, they were there in a foreign environment rapidly without a lot of planning, so they didn't have people on the ground that were doing testing of the environment. There were many chemical weapon alarms, new technologies that seemed to frighten people, but when the validative studies were called into play, the validative, more definitive, less sensitive studies, more specific, were essentially negative with these alarms. Nevertheless, it concerned the veterans who heard the alarms and had to don their protective gear, and sometimes temperatures in excess of 100 degrees Fahrenheit. In addition to these problems, pre-deployment screening was very poor. I mean, they were, the U.S. government and the other governments associated with the coalition focus was to get people in the theater as quickly as possible. And in doing that, sometimes they transported people that had a medical condition that caused them not to be able to function well, especially people with reactive airway disease. It was a leading reason to send people back home. And finally, a number of people were pregnant, a number of women were pregnant and also had to be removed from the theater, evacuated. One of the early findings associated with the deployment that caused a lot of concern among the veterans was an unusual condition, a visceral tropic leishmaniasis that hadn't really seen before. This was picked up through symptomatic, through veterans having symptoms, and then through some rather invasive testing of the bone marrow, and initially caused quite a bit of concern as an unusual infectious disease. However, this was just about the only thing that was well documented from the theater, and it only affected about 12 people in total. However, news magazines continued to present scenarios where there was the suggestion of a Gulf War specific illness and even allegations of U.S. government cover-up. Some of these were very far-fetched, and we'll talk about a Mycoplasma theory from Popular Science, that extensive august journal. But nevertheless, they alarmed the veterans who were reading about this on the internet and caused a lot of concern, as was noted through government officials going to various town meetings. A number of these theories emerged over time, and they're shown here. These are the ones that I recognize, or likely are others. But there were allegations that the Gulf War veterans had experienced biological warfare that had not really caused acute clinical disease, sort of subclinical types of manifestations. There was discussions that since Saddam Hussein and the Iraq Army had used nerve agents in the past, that some of these agents in small exposures were causing the illnesses among the veterans. There were also concerns that pesticide use in the theater, some of it acquired locally and not permitted in the United States, that those sort of compounds might be cause for alarm, or so it was alleged. There was concern that depleted uranium might be a problem, as some of the munitions we had that in it. And then oil well fires, after the war began and the oil well fires began, the exposures were intense, with people reporting that even to drive with all the particulate matter, they had to use windshield wipers. So you can imagine the concern about their exposures to their lungs. And sandstorms, a number of people had postulated a sandstorm or silica-based disease. There were a lot of concerns about petroleum products that had been used particularly to quiet the sand, sprayed on the sand to keep it from getting in aircraft, etc., and petroleum products that were used in heaters in tents, the fumes of which irritated some of the deployed folks. There were concerns about vaccines because the veterans were not told the vaccines they had received. And they said it was to protect against some biological agents, but they weren't well recorded in the haste of administering the vaccines. and a lot of veterans thought that maybe somebody was experimenting on them. One of the prophylactic pharmaceuticals, protistimine bromide against nerve agents, was also frequently administered, and this was exacerbated whenever they had an alarm. They would think about taking that, and a concern because it's an unusual medication. Also allegations that a component might have been used in some of the vaccines, a squalene, a protein from fish. And then there were people that we'll talk about later who said they could find cryptic bacteria in the urine. This is a physician that no one else could see, and that was likely the cause of illnesses among the Gulf War veterans. And finally, we'll talk about a mycoplasma that's rather ubiquitous and not really thought to be a pathogen in most people that was alleged associated. Well, with all these allegations and with historical precedent that the Department of Veterans Affairs had previously compensated veterans for their associated morbidity, the Gulf War veterans began asking Department of Veterans Affairs to look into their health and began wondering about similar compensations. This is a list of the VA's Agent Orange list of presumptive disabilities. And the concept is, of course, if you have one of these disabilities, you can win a funding to help compensate you for those. So a number of the veteran service organizations were concerned that they find whatever illnesses were associated with the deployment so that they too could garner some sort of financial compensation. Well, the popular media was embracing many of these theories and unusual exposures as the cause of illnesses. So they had to do something. And before we get into some of the things that the government officials planned, I want to just preface those things with this little evidence pyramid. It's important to note that, and many of you, of course, have training in this area, so it's not new to you, but we think of an evidence pyramid as shown here with the very highest order of evidence, and actually more difficult to collect and to report, of systematic reviews and meta-analyses, controlled clinical trials like double-blind placebo-controlled trials, epidemiologic prospective or retrospective cohort studies, case control studies, cross-sectional studies, case series, etc. But at the onset, most of the activity that was being reported was down here. Expert and not so expert opinions, case reports, or even case series. I have this illness, my associate has this illness in my former deployed unit, therefore it should be recognized as an associated illness with the Gulf War deployments. So a lot of concern, as well as some animal research with respect to some of the agents used to combat vectors of disease, insects, etc. So let me just pause here. If we could have the microphone passed around. We have an epidemiological conundrum. Many alleged exposures with sparse exposure records and many alleged outcomes, but most are ill-defined and difficult to objectively measure. Let me just see if we have if you could just raise your hand if you have some ideas, and some of you I understand are facing these sort of dilemmas today. How would you approach this conundrum from an epidemiologic standpoint?
One thing you could do would be to look for objective evidence like cancer and establish a cancer registry. What's difficult about this is that not all discharged servicemen use the VA or the service organizations. So therefore, their incidents of cancer are spread out among all 50 state cancer registries.
Okay, very good. Other ideas?
It might work to look for residual from some exposure, a chemical or something else. If it's going to cause the disease later on, it might still be in the body and be analyzable.
Excellent. So look for evidence of exposure based on residual compounds. Did you, Amy?
You could attempt to do some retrospective assessment of exposures based on self-report.
Okay.
Since they were poorly recorded in the record, you'd be relying on people's self-report, but it would be better than perhaps what was available in the record. And I would also think about doing case control studies.
Okay, real good. Well, a number of the things that you brought up were attempted, and actually the spectrum of investigations were really broad, and we can't really do them tremendous judgment, but I'll try to cover a few. One of the first things the government did was call into play expert opinion, and this began with the Defense Science Board and continued, and I don't even think, the Institute of Medicine, I think this year is issuing several more Gulf War veteran studies reports. But these expert panels gave the Department of Defense direction with respect, and the Department of Veterans Affairs, direction with respect to what they should do about these allegations. And there were quite a few of them, and having, if any of you, how many of you here were involved in the Gulf War veteran research elements or studies? Okay, so just one. I don't know how many external reviews reached your institution, but I think at ours we had at least 7 at one time. 7 different organizations, multiple reviews, and so the research benefited from these external peer reviews tremendously, and the government received a lot of good guidance, I think, from many of these boards, although sometimes the board's reports were not in agreement. An example, of course, would be some of the early work. The Armed Forces Epidemiologic Board didn't think that some of the government's later activities were appropriate. The VA Research Advisory Committee has made some recommendations that other, in contrast to the Institute of Medicine and some other groups. And so there's been some debate, but nevertheless, the important thing is that there was a lot of peer review of the government's efforts. Now, it's pretty amazing when you do a PubMed search with the keywords Gulf War here, the number of publications in the medical peer review now count at about 1,170 if you use those keywords. Now, some are case reports, some are perhaps shouldn't be counted in here, but there are just a tremendous amount of literature out there in the peer review system, and there's a tremendous number of external reviews of that literature and recommending actions. I think it's important at this juncture to note that the most current and I think the most comprehensive and balanced review was just published in April in this journal. This is a United Kingdom journal, one of the oldest scientific communities, I think if not the oldest community in the world, the Royal Society. But they dedicated an entire issue to looking at the current body of literature, and much of what I'll share is from that literature. Well, the studies that issued from this situation, the epidemiologic conundrum and the concern, are many. I've classified them here into various different groups: outbreak investigation, health registry case series, symptom surveys, aggregations of symptoms. Can we identify a unique Gulf War syndrome? That was a question. Healthcare utilization, mortality, reproductive health, mental illness, animal studies of alleged toxins, specific exposures. Could we find any in some of the tissues of people? Could we use the existing data, the meteorologic data, the records to map, if you will, through GIS modeling, oil well smoke, munition destruction at Camisea, etc. Can we use self-reported data, and can we use clinical evaluations of people who have taken self-reported taking the vaccines or pyridostigmine bromide. What about the people that have fragments of DU, depleted uranium in them? Are they showing any health effects? All these things were the objects or the focus of various different epidemiologic studies or clinical studies. In addition, a number of different unique diseases were allegedly associated, such as ALS, lupus, fibromyalgia. I think multiple sclerosis seems to be in vogue right now, but I don't know. We've seen a lot of good reports on that. Testicular cancer and Goldenhar syndrome, an unusual birth defect, were all alleged to have resulted from the deployments. It's impressive to think, or it's amazing to think that our government, when you consider all the activities looking into these questions, we've expended about $1 billion thus far. If you consider the risk management organizations that at one time amounted to several hundred people traveling around the country, collecting data, talking to people, reassuring them in some ways, and issuing their own little investigations. The body of research work that was commissioned, the hundreds, I think it's 180,000 people who participated in the registries and had those intensive medical workups that sometimes involved 3 or 4 or 5 different medical encounters in our hospital systems. So a lot of money has gone into this, into answering these questions. Well, the health registries were created first by the Department of Veterans Affairs in 1992. Their plan for doing these registries, these organized clinical evaluations of veterans, changed a bit over time and was revised in 1995. In 1994, the U.S. Department of Defense set up their own registry. In 1993, the United Kingdom, in 1995, the Canadian, and in 2001, the Australian set up a registry. They were initiated to systematically evaluate the veterans' complaints, to try to offer them whatever would be appropriate therapy and intensive, with the current medical technology, diagnostic workup. And in some cases, particularly in the VA, Department of Veterans Affairs, a number of families were also enrolled in these studies. I understand from Dr. Han Khan that a paper is coming out of the family work very soon as it is in press. The health registry concepts involved aggressive recruiting and free priority care. Sometimes they were given hospitalizations just out of administrative purposes because they didn't have a place for them to stay. They'd bring them in from far away. The collection of both exposure data, self-reported, and health outcome data. Systematic clinical evaluations with referral to specialty care when symptoms were unexplained. Often the veterans themselves could be asked to be referred, so it wasn't just enough that a screening physician said, no, your illness is not related. They had some leverage, the veterans, to go get that special consult with orthopedics or whatever. With the exception of the 2001, so that's 10 years later, Australian registry, the registries had really no good control population. So at most they could be a series of cases, or the cases, which exposures were most likely to be associated with those cases. The goals were multiple, but chiefly to satisfy the veterans' concerns and to generate hypotheses. Now, early on, the Defense Science Board, the first expert panel that met, issued this recommendation. The appropriate service facilities should ensure that clinical treatment, absent a proven etiology, is managed by a case-by-case basis directed at the symptoms presented. Carefully controlled treatment protocols might assist in carving out specific syndromes and the broad range of symptoms noted. So this recommendation was, in 1994, well after the VA had initiated the registry, so sort of validating the VA's and then the DOD's registry concept. But what we know about registry participation is considerable. One of the observations that we made in 2 large registry studies of the DoD system were shown here, that the effect of the media was profound on the people making the calls to the registries to participate. So whenever there was a 60-minute broadcast, a news release regarding a chicken study of potential agents, a press release regarding revelations that there was nerve agent destruction at Camasea, et cetera, these had a profound impact on the veterans and resulted in greater calls into the, this is the DoD system, to find out about how they could gain access to care. We know also that Gulf War veterans were sicker than non-participants, Gulf War veteran registry participants, than non-participants, even before the war. We know that the Gulf War veterans who participated in the registry systems were more likely to be Army Reserve or National Guard, greater than 30 years old, female, served near oil well fires, were possibly exposed to Camasea or near Camasea, and were involved with combat. So there were some predictors with respect to participation. It's interesting to compare the Veterans Affairs Registry and the DoD's registry with respect to potential Gulf War exposures. And you can see that high on the list of alleged exposures or things that they commonly experienced were diesel and other petrochemical fumes, passive smoking, skin exposure to fuel, burning trash and feces, etc., aid food other than provided by the military. It's very important to note that not all the veterans who called the registries sought medical evaluations. They just wanted to get their name in the system, and so that if there was something new, they would be contacted. They didn't really feel sick or didn't want to go through the trouble of going into a Department of Veterans Affairs or DoD system. But here you can see that as of 2001, there were 29% of the DoD callers who didn't even want an exam. And in 2003, it was estimated that about 20% had not gotten exams. The veterans experienced or complained of a lot of muscle and joint pain, loss of memory, and other general symptoms. They had complaints of headaches. They complained of severe fatigue and skin rashes. The most common U.S. Gulf War Registry participant diagnoses are shown here, similar to what I just talked about: musculoskeletal disorders, mental disorders, respiratory disorders, and skin conditions. The results were similar across the registries and consistent with the proportional distribution, signs and symptoms, and diagnoses seen in other populations exposed to war. There are some excellent online reports available regarding the registries. Not all of it is in the peer-reviewed literature, including a very nice DoD-VA combined registry report published in 2002. And here you see some of the data with the ICD-9 diagnoses and their prevalence among the participants who completed the questionnaires. Well, this is a list of the conditions that the Department of Veterans Affairs have recognized that were appropriate for compensation with respect to the Gulf War veterans. And this was issued in November 1994. In addition to this, I believe they also are compensating veterans for ALS. And so I'm not quite sure the number of veterans that receive this compensation, but nevertheless, this is the published list. It's important to note in summary of the Gulf War Registry findings that there were quite a wide range of self-reported symptoms, exposures, and diagnoses reported. The symptoms increased over time. There were no unusual illnesses identified that couldn't be explained by previous exposures to conflict. No specific exposures implicated with any specific illnesses. And as of 2001, there were some 12,000 claims of Gulf War-related undiagnosed chronic conditions. Some of these for actually diagnosed conditions, and some for undiagnosed. Now, the only control study of registry participants was performed, again, 10 years after the conflict by among a small portion of the Australian veterans. They implicated a number of different exposures with increased symptom reporting shown here, and it's of interest, but because of the long period of time from the conflict and the exposures to the self-reporting of the exposures and the symptoms, they were really slow to suggest these are very, very strong and not subject to bias. So there's great potential for recall bias and other biases that might fully explain these findings. A lot of the self-reported morbidity was symptom-based, and again, no Gulf War syndrome has been identified from these data. A nice result from the registries have been something called clinical practice guidelines. The first one of which was published recently by the Department of Veterans Affairs and Department of Defense for treating post-deployment health conditions. It's called the Post-Deployment Health Evaluation and Management. And this provides an algorithm of care that all the medical treatment facilities involved with veterans can follow and help discern what is appropriate, what is not appropriate with respect to consultative services, etc. Subsequent to this, there have been a number of other VA DoD clinical practice guidelines published. They're listed here. One for management of major depression, one for medically unexplained illnesses, chronic pain and fatigue, and another for the management of post-traumatic stress disorders. These are thought to be very, very helpful and new products for caring for the veterans. And I thought it might be good to hear just a little bit about some of the things that your institutions are doing in support of those veterans returning from Afghanistan and Iraq. So maybe we could just hear a little bit about some of these programs that we see here.
At the Washington, D.C. VA Medical Center, we've started a transition assistance course, which is a class that's held both during the day and evening hours for new veterans to hear about how to enroll, what the referral processes are, and just sort of a first step course into learning about the VA where they can come in a small group setting and ask questions without having to really just walk into the enrollment office themselves.
One of the assignments, I work in the Women's Health Clinic at the VA, so that's a primary care clinic for women veterans, and an effort's being made to, identify, and I'm a psychologist integrated into that clinic, so it makes it a little bit easier for some of the vets that might not be ready to approach a mental health clinic to get some mental health services. So that's one of the things that's going on. We also have a deployment health clinic that does the exam similar to what was done in the first Persian Gulf War. And they have a mental health provider in that clinic as well, several of them actually.
So another series of new initiatives, yeah.
Yeah, well, these are not, I wouldn't say they're new initiatives, although there's more resources in the deployment clinic now than there was in the past. Yes, that's
But you didn't
new
have a
resources.
deployment clinic probably before 1992 or so.
Right,
Yeah.
right.
Okay, good. What other new things are going on?
Well, we perform neuropsychological evaluations of a lot of the folks that are coming back from Iraq and Afghanistan. There's a real focus on blast concussion injuries, so and about 50% of those persons are actively going through medical boards.
Wow.
And I conduct a brain injury support group, a weekly brain injury support group.
Is your cognitive screening, is that computer-based, or how do you?
Well, for those folks, it's a full day of testing using a Halstead Raytan battery, so it's 8 hours of testing.
Wow. Okay.
The Tampa VA is one of the 4 polytrauma centers in the VA system, and we have an integrated interdisciplinary team approach to dealing with the returning veterans and it's a referral center, so polytrauma victims from other places can get referred to one of the 4 centers.
Okay.
I do know that in the rehab medicine at the VA Seattle, they are just opening a polytrauma clinic. So they got money and grants, so they're starting that. and that's totally, in fact, they're just barely getting into the offices right now, so.
Anything else? Anyone else wants to share about what's going on? It's sort of novel or... Well, in the Department of Defense, there are many different things. They're screening people before they go over. They're screening them when they come back. Often blood samples are drawn, and the questionnaire data are looked at aggressively. There have been an unusual case of a series of cases of eosinophilic pneumonia. There's also been an unusual bacterial infection among some that are wounded that have been discovered through this rather aggressive surveillance. In addition to that, the Department of Defense has got something called the Millennium Cohort Study, and it's a 140,000 person prospective cohort study that was fortuitously set up before the deployment. Dr. Boyko is heavily involved with this. Basically, though, a large proportion of the people in that study that will be enrolled over the years will have been deployed to the recent areas of conflict, and a small portion of them to the first Gulf War. So we have some very good data, both before and after exposure, that will help us better understand and implicate specific exposures. There's also something in the Department of Defense called a birth defect registry, where they're capturing data so that they can look at alleged associations and many other things that I'm sure I don't know about that have greatly enhanced the care of veterans. I know there's a tremendous amount with respect to the post-traumatic stress disorder allegations, the high prevalence of those, and the blast injuries, the subtle ones that are difficult to quantify. Well, this concludes my talk today about about war syndromes and health registries. Thank you very much for your kind attention.